Halo, Assalamualaikum everyone.
Waalaikumsalam. I
Suara
think we can start.
tes. Suara clear ke?
Clear? Boleh dengar?
Okey. Boleh start ya?
InsyaAllah, we can start lah. We semua kita Al-Fatihah. And if Dr. want proceed, please welcome lah Dr.
Okay, sure. Thank you. Okay, let's start the session with Al-Fatihah first. Okay. Let me try presenting my slide first. Can you see my screen?
Yes, Dr. We can see.
Okay, thank you. Okay, let me full screen. Okay. You can see the full screen, right?
Yeah, we can see.
Okay. Okay, Assalamualaikum warahmatullahi wabarakatuh and good morning everyone. Okay, insyaAllah today I would like to share a really good topic that we should learn for the purpose of our final professional examination and the uses for our future as doctor as well. So the topic that I was given is hernia. So but before that, I would like to introduce myself. My name is Hami Riza bin Muhammad. You can just call me Hami. So any question that you like to ask during the session, you are welcome to ask. Okay, can I proceed? Okay, can you see this page of my slide, the content?
Yes, we can see.
Okay, thank you for the response. So today, for the topic of hernia, there are two subdivision, which basically is divided into two parts, which is theory and clinical. But unfortunately, honestly, I will touch more on clinical only because the theory is so much things. There are so many things that needs to cover. So for the theory part, I would like to list only on what things that you should know for the preparation of your examination. Okay, and for the clinical, I will discuss more details on it. Okay. So first of all, yes, for the theory, this is some list of the topics that you should cover. It includes the definition of hernia, types of hernia, the epidemiology, the anatomy. So certain list in this theory part, I highlight with green color because this one you should it can be covered in both part, which is theory and also and clinical as well. So it includes the anatomy, the sign and symptom, risk factors, complication of hernia, the differential diagnosis, investigation and management. So for this list of the theory for the hernia, you can self-read by yourself later on. For the sake of the time being, due to that the fact that uh, how uh, how many men you got left before the professional examination? Berapa lama lagi nak pro exam? So due to short time, I would like to suggest that you can read some simplified note for your information. During my time, I just read the bare for the surgery lah. That is enough, I think. Okay. So let us discuss on the clinical part for this topic. So we start off the history first. So honestly, during my time for professional examination, there's none of us that get a hernia case for long case. So better you prepare well for this topic, because previously my mentor suggests to focus on this topic. However, it doesn't come during my years. There is big probability that during your time it will come out. So, for example, if there is a patient hernia case in the long case, so we start with history first. So first of all, you need to know the main complaint for patient with hernia case is uh, Islam or Bash. So first of all, in any presentation or in any case, regardless of which posting, such as medical, orthopedic, and so on, first of all, you must dig or ask detail about the chief complaint. So for the hernia, the patient will complain about the presence of lump. So first of all, we need to ask where is the exact location of the lump. So for the patient, usually they will not tell that it is a groin or scrotal area. They will use the layman term lah. For example, they will say at the peripat ataupun area kantong telur, which is a groin and scrotal area. Then we need to ask on which side the presence of the lump, and then how long does the lump already present. This is important because we need to know. For example, if the lump is also already present for 3 months, why does the patient come after that 3 months? Why not at the first day of presentation? And then how about the progression within that 3 month periods in the term of the size and also extension? How severe is the presence of lump? Is it previously reducible and now become irreducible? Is it a first episode or recurrent? And then after we complete asking about the detail about the lump, we need to ask about the associated symptom, because why associated symptom? This is the main, I think, this is the main point. Why does the patient come to seek for the medical attention? Because honestly, I think there is no patient with hernia. They come just because there is only presence of the lump. It must be there is a certain symptoms such as the lump already become painful. Patient come with presentation of their vomiting and also constipation and so on, because that suggests that the patient has already developed complication from the disease. For example, if the patient have severe pain at the location of the lump, it might suggest the strangulation of the hernia. Meanwhile, if the patient complain of vomiting, episodes of vomiting, chronic duration of constipation, patient already develop obstruction from the hernia. And then the risk factor. Why does this patient can develop hernia? So this point is also important, because for your information, during your clerking, the examiner will have the scheme for the marking. So if you don't ask about the risk factor, you will miss certain points. So there are several risk factors for hernia, such as chronic cough, constipation, and urinary retention. So for your information, why does this patient can develop hernia? Because all these problem actually can simply say that it can raise intra-abdominal pressure, and then will cause patient to straining, and eventually lead to development of a hernia. Certain occupation like lifting heavy weight, such as contractors, you should ask them as well. And about the lifestyle, lifestyle include what does the patient eat? Does the patient eat adequate intake of fiber, such as vegetable and fruits? Because if no, this is the reason why then a patient suffer from constipation and then lead them to frequent straining and development of the hernia, and then previous abdominal surgery, because you know that if there is abdominal surgery, uh, following the surgery, it will left certain scar at the abdomen, and then the scar is the weak point of the abdomen in which the hernia can develop. Okay, so far, can you still follow me, or am I going too fast?
Can.
Okay, thank you. So I think that's all for history. Uh, to simplify, for any cases or any disease that you get in your examination, there are several things that you need to focus on to get the diagnosis and also to provide the other differential diagnosis. First, you need to ask detail about the complaint, such as the lump in these cases. So first is the chief complaint, ask detail about the chief complaint, and then the second, the causes of the problem. The third one is the risk factor, and the fourth one is the complication. These are four things that you need to know and need to ask during the clerking. Uh, the other things like family history, social history, if you have adequate time, you better ask lah. But these four things, you should not miss. And then proceed with physical examination. So for let's say that you don't get hernia patient in long case, but they are stationed in short case that provide patient with hernia. So I give two situation, two possible scenario for patient that will come out during a short case. First, the instruction might say that this patient has hernia, so it asks you to perform the abdomen examination. So in first scenario, how you like to examine this patient. So first, you should examine this patient as what you have done in abdominal examination. So the position is you lie the patient in supine position, and then for inspection, you inspect the abdomen first, and you look for the hernia orifice. So when you ask patient to cough, when you inspect for the hernia orifice, if you see there is presence of hernia, you proceed and bring the patient to stand up and proceed with hernia examination. However, there is certain instruction that, for example, the doctor or examiner asked to directly examine for hernia. So you don't need to ask the patient to lie in supine position. Then what you should do, you should ask the patient untuk diri siap-siap, tayar baring dulu. To stand up and don't need to lie in supine position first. Clear ke?
Boleh.
Okay. So in hernia, for hernia examination, the position of the patient, we need to put patient in standing position, and for the exposure, we need to expose uh, to remove the whole uh, covering from the umbilicus until the leg lah. Okay. Remember, for any case that you get, you need to put in mind about the universal precaution, because this also contribute to your point, to the marks in your examination. For example, ask for the consent, you introduce yourself and your examiner, and then hand rub, put the patient in a proper position. For example, in hernia cases, you put patient in standing position, respect patient privacy. If there is langsir, you tutup, and then exposure, remove all the undercloth. Okay, and then back to basic. If you suddenly become blank, back to basic, that every examination it comprise of inspection, palpation, percussion, and also auscultation. But for hernia cases, as simplify, this only four as well. It include inspection, palpation, auscultation, and also special tests. Okay, let's start with the first step. So after we have introduced ourselves, introduce our examiner, and then we also provide a good exposure. We have done hand rub, and then okay, and then first thing that we should do is inspection. So inspection, what should we do? So inspection, first we look at the side of the lump because the patient complaint itself is the presence of the lump. So we need to inspect first. Where is the presence of the lump? Because from this inspection, we already can know what is the most probably the diagnosis. For example, so for inspection, we look where is the presence of the lump. Is it the above of the inguinal fold or below the inguinal fold? Because the most, I will say that the most top two diagnosis for hernia, it can be either inguinal hernia or also femoral hernia. So if you can see that there is inguinal fold, if it is above the inguinal fold, the lump is more probably inguinal hernia. Meanwhile, for if it is located below the inguinal fold, it most probably femoral hernia. Back to anatomy, because inguinal hernia is located above and medial to pubic tubercle. Meanwhile, for the femoral, is located below and lateral, right? Okay, there is some ideas, but you cannot confirm yet unless you have complete all your examination. So that is the first one, the side. Where is the presence of the lump? Is it above or below the inguinal fold? Which side, left or right? And if the present, if is only present of left, make sure there's only one lump. There's no bilateral lump. You need to confirm that. And then what is the shape uh, of the mass? Is it a piriform or hemisphere? Because this one it can differ between indirect and also direct. For direct hernia, the lump is usually hemisphere circular in shape. Meanwhile, for indirect hernia, it is more about ovoid or piriform in shape. And then you need to see the skin changes. Does the skin over the lump become reddish or blackish? Because why? Because one of the complication of the hernia itself, it can become first it can become insacerated and then become obstructed and then strangulated. Once it becomes strangulated, the content of the hernia, such as the bowel, it can become ischemic, and then it can be found from examination that the skin changes will become reddish or even blackish in strangulated hernia. And then the scar, presence of scar, this is because we need to confirm that does this hernia develop because there is previous surgery at the location of the lump, because uh, it is a risk factor for the patient to develop the hernia. And then from the inspection, we need to ask the patient itself to cuff to see for visible cuff impulse, because from this inspection of the visible cuff impulse, we need to look for the direction of the bulging of the mass. Is it bulging forward or bulging downward and medially? Because this also to differentiate between the direct and also indirect hernia. Okay, next one is palpation. After we done inspection, the next step is palpation. So what we need to know from the palpation, first is about tenderness. This one, you should ask the patient first lah. Does the lump itself is painful before we touch? And then we need to touch it gently, and then feel on the lump and ask the patient, is it painful? And then try to appreciate the size, the temperature, consistency, surface and border. The next thing is can get above the lump. This one is more towards the scrotal lump, because this one to differentiate, is it the scrotal lump originates from purely from the scrotal, or is it originates from the abdomen? For example, I give example to you. Let's say this patient have scrotal swelling, and then we try to appreciate, can we get above the lump at the scrotal? if we can get above the lump, it is a purely scrotal mass. For example, scrotal carcinoma. However, if we try to palpate the scrotal swelling, but we can't get above the lump, it suggests that it originates from the bowel. That means it is already become an inguinal scrotal hernia. And then for hernia, during palpation, we need to check for reducibility. Uh, this one for the reducibility, we need to ask the patient first, can he or she reduce the lump by himself? If cannot, we try to reduce it for the patient. And then from the reducibility, we need to observe why the patient reduce the lump. We need to observe the direction, how the patient reduce the lump. This one also can differentiate between the direct and indirect inguinal hernia. For example, if the patient reduce the lump directly backward, it means there is more towards direct inguinal hernia. However, if the patient try to reduce upward and laterally, it more towards indirect inguinal hernia. And then once we have reduced the lump, the next important test that we should do is occlusion test. This one you need to uh, show properly to the examiner how you allocate the point where to occlude the point to prevent the lump from become bulge back. So the most accurate point to occlude the mass is at the uh, at the deep inguinal ring. So how to find the deep inguinal ring? Anyone like to share the answer? Okay, test. Sekejap, saya just nak make sure korang ada lagi. So, saya nak try tanya. Kalau kita reduce, if we reduce the lump, after we reduce, and then we have to do occlusion test. And then point kat mana tu kita nak tahan, nak occlude lump tu daripada bulge semula. Anyone nak try tak? Okay, sure brother. Okay, where is the midpoint of inguinal ligament? How do you find a midpoint of inguinal ligament? Okay, thank you. Good try, brother. So the point for the occlusion test, yes, the brother is correct at the midpoint of inguinal ligament. So as the name suggests, inguinal ligament means the connection of two bones, right? So the two bones, bony landmarks included is at the pubic tubercle and also at the anterior superior iliac spine. So midpoint between spine. That is the midpoint of the inguinal ligament. So, but it is not that easy. But because you need to demonstrate to the examiner the proper way how to find the midpoint of inguinal ligament. So let me teach you. So to look for the midpoint of inguinal ligament, so you need to start at the umbilicus of the patient. So find the patient's umbilicus, put your finger there, and then go straightly downwards until you find the pubic symphysis, and then move slightly laterally until you feel the first bony prominence, which is the pubic symphysis. After you have found the pubic symphysis, find axis anterior superior iliac spine, then try to allocate where is the midpoint between these two bony landmarks, and then approximately try to find 2 cm above of the midpoint. So that is the point of deep inguinal ring that we need to occlude for the examination of the hernia. Okay, you guys dapat tak? Okay, laju sangat.
Dapat.
Okay, so bila dah reduce, bila kita dah tahan dekat uh, occlusion point tu, and then what we need to do, what we need to instruct the patient, we need to ask the patient first to cough again, because we need to ask, we need to feel, the direction of the lump. Does the lump budge and touch our finger? If the budge directly touch our finger forward, that means it can be direct hernia. However, if it move horizontally or obliquely, it more towards indirect hernia. That is the first thing. The second thing, on cough, after we have instruct the patient to cough, when we occlude, does the uh, does the does the lump is still occluded or already budged out? If it is already budged out, that means it is a direct hernia. But if it's still contained in the abdomen, it means it is more towards indirect hernia. Okay. Okay, and then for auscultation, on the lump, we need to appreciate the bowel sound, because this one also we need to appreciate the complication of the hernia, because once it's become obstructed, there must be reduced bowel sound. Okay. At this slide, I also include how to know. Okay, for the hernia, for your information, the content of the hernia, it can be either bowel or omentum. So from examination, from the inspection, palpation, and also auscultation, how can we know the content of hernia is bowel or omentum? You know, omentum is just like a fat. So how to know whether the content of hernia is bowel or omentum?
Bawal
And like,
sound.
okay, sorry.
Bawal sound.
Okay, true. For bowel sound, for omentum, uh, how does it suggest? Okay, true. Okay, that is from auscultation. And then how about the palpation? Um, okay. Okay, nice try. But for bowel, because bowel, they got peristalsis, right? So on palpation, we can feel the gurgling sensation that suggests that the bowel is moving. However, for omentum, there is no peristalsis. We can palpate for any gurgling sensation for omentum. Okay, that is how to differentiate between the bowel or omentum of the content of the hernia. And then, okay, we have done inspection, palpation, and also auscultation. Last but not least is spatial test. So this one is only done for scrotal swelling only, because this one to differentiate uh, whether there is a solid mass or is it a fluid content mass. So the special test that we done for scrotal swelling is trans-illumination test. Sorry. So if the trans-illumination test is negative, so it suggests that the content of the mass is purely solid lah. For example, scrotal carcinoma, inguinal scrotal hernia. However, if there is a positive trans-illumination test, the mass is transilluminated from the test, it means that it contains a fluid. For example, in case of the hydrocele. Okay, once you have complete doing inspection, palpation, and auscultation or special tests in scrotal swelling, you need to offer to the examiner, please offer to the examiner that we like to complete the examination with what examination, because this also contribute certain marks in our examination. So for hernia cases, uh, we should offer to examine the abdomen to look for any presence of other mass at the abdomen, presence of ascites, check for ascites, and presence of any other scar, because this is a potential area to develop hernia as well. And then for parietal examination, we need to palpate for any mass such as in BPH, in prostate cancer, or if the patient have prolonged constipation, chronic episode of constipation, we should appreciate for any impacted stool. And last but not least, respiratory examination for the risk factor of the hernia, which is chronic smoker. So chronic smoker usually have COPD, right? So the finding that we need to look from the respiratory examination is bronchi. Okay, that's all from the examination. After we have complete the examination, and then we have found all the findings, so we need to offer full diagnosis. So the objective actually from the examination, first we need to differentiate whether it is a femoral or inguinal hernia. That is the first step. After I say that, we need to look at the site. Where does the lump located? Is it above or below the inguinal fold, right? That is from the inspection. And then, is it inguinal or inguinal scrotal? Look, is there any scrotal swelling? If not, that's mean the mass only restricted on the inguinal area only, not extend yet until the scrotal area. Is it reducible or irreducible? This one from the palpation. Is it direct or indirect? Also from the palpation. Last but not least, if there is scrotal involvement, there is scrotal swelling, we need to perform the special test, trans-illumination test. Okay, for hernia cases, how you should offer the full diagnosis. First, the location. Which side is involved? Is it the left? Is it left? Is it right? So, for example, there is right. Is it reducible or irreducible? Reducible. Is it direct or indirect? Indirect. Is it purely inguinal or already extend until scrotal area? So it's already become inguinal scrotal. So the full diagnosis, for example, I give is a right reducible, indirect inguinal scrotal hernia. Okay. Okay, next. So for hernia cases, these are several differential diagnoses that you can think of. But usually, I can say that for hernia case, the most close to diagnosis is only inguinal and femoral hernia, inguinal, femoral, or inguinal scrotal hernia. The other diagnosis, this one are good to know. And then for hernia cases, if you get this case, I can say that you are lucky as well, because for hernia, the diagnosis is fully made through clinically, because for hernia, there are no radiological evaluation to confirm diagnosis. Most of the diagnosis is obtained from the history and also clinical examination. But there are several investigation that can be considered helpful in hernia. For example, the abdominal X-ray in the patient. If the patient complain of sign a complaint or already developed sign of obstructed intestinal obstruction, for example, obstructed hernia. So we can offer abdominal X-ray to look for signs of intestinal obstruction. For example, dilated bowel, accumulation of gas in bowel, and so on. Okay, last but not least, in the management. So for management, for hernia, the definitive treatment is surgery. However, in hernia, we also have a conservative treatment for hernia, but in which case, for conservative treatment is only reliable if the hernia is only small and the patient doesn't develop any complication yet. Okay, so for conservative treatment, we can suggest patient to avoid the risk factor, for example, to reduce or stop smoking, uh, take a large consumption of the fiber of such as vegetable and the fruits in the diet. But if the patient complain that the mass already become large or it disrupt patient's quality of life or become uh, or develop several complications, so the treatment is surgery. We need to do the surgery. So there are several types of surgery that you need to know for hernia. So for hernia, there are two options mainly, which is open and also laparoscopy. So for open, there are three examples of it. For example, herniotomy, hernioplasty, and also herniorrhaphy. So for every example of this type of surgery, you need to know basically what does this surgery or this procedure mean, and then what does the advantage or what does the disadvantage. Plus, you need to know the principle, the brief principle of the surgery. Okay, first herniotomy. The herniotomy simply can be simply defined by excision of the mass and also the removal of the hernia sac. That's it. I repeat, herniotomy is excision of the mass, excision of the mass and the removal of the hernia sac. There is no repair in herniotomy. So for herniotomy is the most suitable option for peds patient. Meanwhile, for adults, we usually done hernioplasty and also herniorrhaphy. So for hernioplasty, we excise the mass and then we remove the hernia sac and last we repair. In herniotomy, there is no repair, but hernioplasty and herniorrhaphy, there is repair. But for hernioplasty, we repair with surgical mesh at the posterior wall of the cavity. Meanwhile, for herniorrhaphy, we repair with suture at the posterior wall. Why posterior wall? Because this posterior wall is the entrance where does the bulge or the lump comes out. Okay. And then open versus laparoscopy. So these two also got advantage and also disadvantage lah. For open, is readily available, which mean we there is no need of the macam mana cakap, for open the surgeon is already available lah, because for laparoscopy only highly trained surgeon can only perform the laparoscopy. But for laparoscopy, because there is only a small incision hole then at the abdomen of the patient, so the advantage from the laparoscopy is short recovery time and then short duration of stay in the hospital. Okay, that's it. So these are several images that I provide. The left one is actually want to show the presence of hernia. So hernia basically contain of three parts, which is the content, and then the sac, and also the covering. And then once we have repaired, so this one we done hernioplasty, by which we introduce the surgical mesh at the posterior wall of the cavity. So take note kita tak buang pun dia punya bowel tu, kita remove dia punya sac je. We only remove the hernia sac, the content we reduce it back, and then after that we close the opening with the surgical mesh. Okay. Every disease got its own complication and also ni lah. Every disease and treatment got its own complication. So for hernia itself, there are three complications that we need to know, which are incarceration, obstruction, and also strangulation. So we have discussed about the history and also physical examination in hernia. So how to assess the complication of the disease of the hernia clinically? So, how to know that the patient develop, for example, insaturated hernia or obstructed hernia or strangulated hernia from the history or from the physical examination? Anyone would like to ask? Like, dia nak try tak macam mana from history dengan examination kita boleh tahu patient ni develop complication from hernia. Okay, tak apa. Okay, for example, first insuturation. Insuturation, the definition is chronic irreducibility of the hernia without any obstruction and also strangulation. So from the history, apa kita nak tanya from patient, how long does first it means chronic irreducibility. So first chronic, we need to ask how about the duration lah, dah berapa lama. So usually insuturation already developed 4 months, and then irreducibility, we need to ask the patient, does the mass is reducible or irreducible. So if it's already present for long periods and it become irreducible without any signs of obstruction or strangulation, so it means there is insaturated hernia. Then from the examination, we can test itself lah, is it the mass irreducible or not? If irreducible, so it means it is insaturated lah. And then the second thing is it obstruction? How to know from the history that this patient have obstructed hernia? Does the patient have the symptom of obstructed bowels? For example, vomiting, abdominal distension, abdominal pain, constipation or obstipation, cannot passing out flatus. So if this patient have hernia and also this intestinal obstruction symptom, so it means that this patient already have obstructed hernia. And then from examination, how can we know there is obstructed hernia? At the lung, we try to auscultate it. Does the bowel sound is normal or reduced or absent? If it is reduced or absent, it means that it's already become obstructed. How about strangulation? For strangulation, since this is the last stage of the hernia, because once it's become the once the hernia become strangulated, the blood supply to the bowel is become compromised. So patient will complain of severe pain at the side of the hernia, at the side of the mass, and then very tender to touch. And from inspection, you can see that at the surface of the skin, it already become reddish or even blackish. So strangulation is the most emergency situation lah in hernia. So for strangulation, I forget to share. For strangulation, which one we should choose, either hernioplasty or herniorrhaphy. So for strangulated hernia, we can do hernioplasty. Herniorrhaphy is better because for strangulated hernia, the risk of contamination is higher because it already become ischemic, and then once it become gangrenous, it can be a site for the infection. So there is a lower risk of infection in herniorrhaphy as compared to hernioplasty, because hernioplasty we will introduce um, the mass, right? So it is like just like a foreign body lah. And then there is the complication of the disease. How about the complication of the treatment itself, which is surgery? So for the complication of the surgery itself can be divided into three. It include immediate, early, and late. For immediate one is due to iatrogenic causes, which is from the surgery itself. For example, it can cause injury to nearby structure such as the nerve, the pelvic nerve. So patient might complain of having acute episode of urinary retention. So the immediate complication of the surgery is acute urinary retention, and the early complication of treatment it present after 2 days up until 1 month. So the most common early complication for surgical treatment of hernia include post-operative pain and also infection at the site of the operation. Last but not least, late complication of the hernia repair after 1 month. The most common late complication of the surgery for hernia that we are concerning about is recurrence. So how about the post-operative management? So for post-operative management, the principle is we need to observe or tackle the complication of the surgery, such as the acute urinary retention. So post-operative, we need to check for the urine output, and then we should cover patient with adequate analgesic for post-operative pain, and then for late complications such as the recurrence of hernia, we should advise patient uh, to avoid modifiable risk factors such as lifting heavy objects, and also we need to encourage patient to take a lot of fiber, and advise patient as well to quit smoking because you know that if you are smoking, patient can have episode of chronic cough, and then patient can develop another episode of hernia post-operative. I think that's all. That is my last slide. Ada apa-apa nak tanya ke? Is there any question that you like to ask? So for the surgery of the hernia ni, basically there are several example. But that one is good to know lah. For example, hernioplasty, the most common example that we do is Liechtenstein. For herniorrhaphy ni, example shoulders or bassini. This one detail sangat kot. Bukan level kita. Unless kalau orang nanti nak sambung surgery, bolehlah baca-baca sikit. Tapi good to know, but no need to know. Istilah laparoskopi ni pun ada dua jenis. Ada TAPP dengan TEP. Itu pun tak payah baca detail pun tak apa je. Apa ada question ke? Okay. Apa tu? Hernia. So that one we call hernia thrust. Thrust or thrust. I will Google it for you. Can you see my screen? This one. This one the hernia bags. Is it post-operative, Ibrahim? In a few days, because this one is included in conservative treatment. The one that I said before, if the mass is small and then the patient doesn't have any complaint of pain, so you can offer this patient to wear this hernia truss as a conservative treatment lah. But I'm not sure for the patient in the ward, why in the ward or the clinic, Ibrahim? In the ward. So I'm not sure lah. Maybe to prevent, not sure. But the idea is you want to hold the mass. Okay. Any other question? Oh, sorry, ada chat eh. Okay. Okay, for obstructed hernia, through PE, we have checked for reduced or absent bowel sound. Is there a specific cut-off point for us to say that it is a reduced bowel sound? How long should we auscultate the patient? So ideally lah, for normal bowel sound, we should auscultate for a minute lah, 1 minute. So for normal bowel sound, so for normal bowel sound, usually about if I'm not mistaken lah, 8 to 10 in a minute. So below than that, is considered reduced. Okay, welcome. Lagi ke soalan lain? Sorry lah kalau saya laju sangat ni. Korang faham ke? Dapat nanti saya share semula slide saya.